This video continues Chapter 11 of OEC 6, and we're going to take a look specifically at the assessment of patients with AMS. So we'll talk about using this acronym, FAST-ED, to talk about someone who may be having a stroke, and more broadly about assessment of a patient with altered mental status. Now keep in mind some of the causes of AMS could be something like epilepsy, they could be something like diabetes, they could be something like a stroke. We'll address each of these. When we consider AMS, we want to look for what the underlying cause is, but determining that's going to be pretty tough because in a lot of times the patient's communication is going to be altered. So interviews with family members or bystanders that give us a good patient history, or particularly in the case of diabetes or epilepsy, a medical alert tag, either on a necklace or on a bracelet, is going to give us a little bit of a clue. Consider the age group that might be involved as well. In the case of older individuals, we may have something like heart problem or stroke. With all assessment, we begin with the idea of scene size up and making sure that we begin with scene safety. Part of that scene size up is to think about the MOI or the NOI, traumatic injuries, MOI, medical things, nature of illness, but understand that they can occur together. If trauma suspected, make sure that we consider spinal motion restriction as we evaluate the MOI. We move on to our primary assessment, making sure that ABCDs are addressed, any life threats. But in this case, dealing with a patient with altered mental status, we want to really consider where they are on the AVPU scale in terms of level of responsiveness. Make sure the airway is open, of course, and in an unresponsive patient, open the airway, check for breathing and a carotid pulse. We may need to go down our CPR algorithm and activate ALS if the patient is unresponsive and has no pulse. For the patient history, the sample history can give us a little bit of a clue, but if the patient has altered mental status, it's going to be a friend or a relative that's going to help you with that, or finding that medical ID tag, either bracelet or necklace. Sometimes patients have cell phones with their medical information, or even QR codes that can appear on their snow sports helmet. We're going to use our AEIOU TIPS mnemonic to assess for altered mental status. Now, part of this is also going to be considering the onset time. And we may not be dealing with pain and following through the OPQRST mnemonic, but determining the onset time for AMS, especially in the case of a stroke, is going to be critical because one of the higher treatments that can occur when the patient arrives in a hospital is implementing clot-busting drugs if it's appropriate. If the patient has had a seizure, also noticing the onset is going to be helpful in determining whether the patient has perhaps moved to status epilepticus, which is a medical emergency. Does the patient's speech appear impaired? Are they slurring or misusing words, or is their speech incomprehensible? Part of our AEIOU tips is considering the idea of intoxication or these other things like hypoglycemia, stroke, or a behavioral condition. If they're perseverating, it could be the idea of a brain injury that has occurred in the case of an MOI indicating trauma, but if that's not the case, it could be related to diabetes. Look closely at the patient's pupils in your head-to-toe assessment and look inside the patient's mouth. When you assess the pupil, consider both size and response. Remember our acronym PEARL, pupils being equal, round, and reactive to light. Well, pinpoint pupils could be associated with the narcotics overdose, and the idea of unequal pupils, the E in PEARL, could indicate some sort of pressure within the brain, some sort of a hematoma, and that could be the result of a hemorrhagic stroke. That is a not good sign, unequal pupils. Examine the mouth and consider what may have occurred there. Also, part of our initial scene size up, but we want to pay attention to it in our deeper assessment as well, is the patient's skin, because pale moist skin could be due to shock, which we always need to be careful of, or hypoglycemia. Hot, dry skin, if it's not an environmental injury, and the possibility of heat stroke or hyperthermia could be due to hyperglycemia. Also need to consider the idea of sepsis and septic shock. To check higher cortical function, have the patient perform a task. Hold up 2 fingers on the right hand. They need to process the request and then follow through with the proper motor signal to the hand. If you see a delay in performing the task accurately, you've got an idea of this altered mental status. Repeat a phrase such as bananas are yellow, apples are red will also help assess brain function, especially around those centers of the brain that deal with speech. For a stroke, you need to recognize that immediately and understand the patient needs further evaluation at a hospital. So we may see hemiparalysis, that is paralysis on only one side of the body. Speech and language could be affected as well. This is going to be alongside our decreased responsiveness or change in altered mental status. Other signs of a stroke could just be disorientation or the inability to do procedural tasks that they're likely able to do, typically without thinking. If we see ataxia, stumbling, or clumsiness, or an unusually severe headache, this also could be part of a stroke. If the symptoms have resolved, then we get that lesser idea of a transient ischemic attack, where we had a brain blockage that resolved itself. Now, to help with our assessment, we can use this mnemonic device, FAST-ED. We're going to look F for face drooping. This is part of that hemiparalysis, and it's just specific to the facial muscles. We can see drooping of the corner of the mouth and sagging of the facial skin, that kind of loss of the tone of the skin on that side. Arm weakness will also appear. If a patient raises both of their extended arms and then closes their eyes, we may see drift or lowering of the arm on one side. Also, grip strength will change, keeping in mind that we're really considering this case their ability for motor function. The last part of our FAST-ED acronym, S, speech difficulty, that's slurring speech or inability to repeat a simple phrase. And what you need to do then is respond with calling for medical care. Call 911 immediately. And if possible, make sure that you can describe to 911 the onset of the condition. Eye deviation, extraocular eye motion, or denial or neglect. If you have a positive finding and the patient denies the problem, we need to consider that as well. So this accurate time of onset can be part of our handoff report to the ambulance. Any patient presenting with AMS should be evaluated even if the signs are improving. Why? Because early detection and rapid transport can help improve patient survival after a stroke.